Welcome to the Osteoarthritis Action Alliance Lunch and Learn for February 2016. My name is Kirsten Ambrose, and I appreciate all of you taking the time to join the webinar today. I'm pleased to introduce our presenter, Dr. Kenneth Cameron. Dr. Cameron is Director of Orthopaedic and Sports Medicine Research, the John A. Feagin Jr. Sports Medicine Fellowship at Keller Army Community Hospital in West Point, New York. Dr. Cameron's primary research interests are in the areas of injury prevention, musculoskeletal injury and disease epidemiology, and outcomes associated with the treatment of these injuries, specifically in physically active and military populations. He also has research interests in knee and ankle injuries, shoulder instability, and biomarkers associated with post-traumatic osteoarthritis. He has authored or co-authored more than 60 peer-reviewed publications and several book chapters, and has presented his work at professional conferences nationally and internationally. This past year, Dr. Cameron was one of only 2 individuals honored as a 2015 National Athletic Trainers Association Fellow at their national convention in St. Louis. The NATA Fellows Program recognizes professional achievement in research and/or education combined with service to the profession, so this is a nice honor. Today, we will learn about acute traumatic joint injury and osteoarthritis in military populations. Welcome, Dr. Cameron.
Thank you, and thank you for the opportunity to present during your Lunch and Learn session today. Just to get started, anything I say is my own opinion and does not represent any official policy. And I will be talking a little bit briefly about a book that we were involved with. So just for full disclosure, I want to put that out there as we get started. So during our session today are a few key points that I would like to discuss. First of all, I'd like to focus on the risk of acute traumatic joint injury in military populations and the association between joint injury and osteoarthritis. In this population, we'll also discuss the role of primary prevention for joint injury, as well as secondary and tertiary prevention efforts for OA following joint injury. I'd like to discuss the incidence and burden of OA in military populations, as well as how OA is related to disability discharge in the military. And then finally, I'd like to discuss some potential contributing factors and also potentially some solutions that can help deal with this problem. So we did a series of studies looking at the incidence of acute traumatic joint injury within the military population. To do this, we were able to use the Defense Medical Surveillance System because all military service members receive their health care through a closed health care system. We actually have pretty good surveillance and follow-up as long as folks are on active duty, so we were able to do this quite well. And so first, one of the first areas that we looked at were ankle injuries. We looked at ankle joint injuries, and one of the key findings, again, was that ankle sprains were 5 times, the incidence rate of ankle sprain was 5 times higher in military service members when compared to the general population. And it really should be no surprise when these are the types of activities that our military service members are doing on a daily basis, whether they're in physical training or military training. They're doing activities that place them at high risk for lower extremity joint injury. We also, some colleagues of mine also looked at the incidence rate of ACL injuries within the military population. And again, the incidence rates compared to the general population were 10 times greater than those that have been reported previously. We also looked at meniscus injuries within the knee joint, and again, the incidence rates were much higher in the military population than compared to the general population. One of the unique things that we saw when we looked at the fibrocartilage injuries to the meniscus in the knee was that incidence rates were fairly low in the younger ages, but increased significantly with age. We also saw that in the shoulder when we looked at the labrum and the fibrocartilage in the labrum of the shoulder, whereas other joint injuries to the ligaments particularly happen at greatest incidence rates in the youngest of military service members, and then those decrease with increasing age. And again, the incidence rate was over 10 times higher when you look at the military population compared to the general population. We also looked at patellar dislocation injuries to the patellofemoral joint, And again, incidence rates were over 10 times higher in military populations when compared to the general population. As you look here, the rates that we observed were very similar to rates that were observed and reported for in a study that was conducted in the Finnish military as well. And again, those rates were much higher than those that have been previously reported in the general population. So we haven't just looked at lower extremity injuries. We've also looked at upper extremity injuries, particularly in the shoulder in terms of shoulder dislocation and instability. And again, the rates in the military much higher than we typically see in the general population. And we see even higher rates in military cadets than we typically see in the general military population. But again, you look at the bottom of the slide here. When our folks are engaged in these types of activities on a regular basis, it's not surprising that there are shoulder injuries, both overuse and acute traumatic injuries to the glenohumeral joint. So we recently, in a review paper, summarized much of this literature. And again, I think one of the key findings is that acute traumatic joint injury is endemic in the military populations. We see this on a regular basis. So we see it in several joints in the lower extremity and in the upper extremity, and that causes significant problems. And some of these problems primarily are that they lead to long-term problems. And these musculoskeletal injuries don't just happen in training, they happen during deployed settings. Acute traumatic joint injuries to the lower extremity are one of the most common reasons for people to be evacuated from both Operation Iraqi Freedom and Operation Enduring Freedom during recent conflicts. And these are non-battle injuries. So these are injuries that are not sustained during battle, and people are much more likely to be shipped back home or out of theater for these types of joint injuries, which are, again, primarily due to participating in sports or physical training, or even potentially just jumping down out of a truck. So hopefully this kind of paints a picture that acute traumatic joint injury is common in military service members. And one other thing that I want to talk about is that once somebody has an injury, they're much more likely to sustain a follow-up injury or another injury to that joint, but also another injury to other joints in the lower extremity. So this is a study, and I'll use my little pointer over here. This is a study where we looked at people who had a history of lower extremity injury to the knee and to the ankle and to the hip when they entered military service at West Point. And if they had a history, they were much more likely to sustain an injury going forward. So these are rate ratios over here. So people who sustained a hip injury previously were 4 to 8 times more likely, both males and females, to sustain an injury. Same with ankle sprain. If they had an ankle sprain before, they were 3 to 5 times more likely to sustain an injury going forward during their military training. And same thing to the knee. We saw that they were almost 5 to 6 times more likely to sustain a follow-up injury. And again, it didn't really matter. If we look at this, it didn't really matter if they had a prior injury to the knee or a prior injury to another site in the lower extremity. They were much more likely to, again, re-injure their knee or re-injure their ankle going forward. And also, we haven't just looked at the lower extremity again, so this looks at survival curves for shoulder dislocation or shoulder instability. The blue line up here at the top are people who entered military service with no history of shoulder instability. And the red line are people who entered military service with a history of shoulder instability but no prior surgery. So you can see that these people are sustaining follow-up instability events much more rapidly, almost 5 times more likely to sustain a follow-up instability event if they've had one in the past. So again, this really points to the role of primary prevention of these joint injuries, which is really critical. We not only know that people who sustain these joint injuries are much more likely to re-injure their joint or another joint in the lower extremity, but they're also much more likely to develop osteoarthritis. Prior studies have shown that in the shoulder, 33% of shoulders examined with CT prior to initial shoulder stabilization surgery had signs of OA, and that the number of prior instability events were associated with the degree of degenerative changes that were observed. We also know from well-designed prospective cohort studies like the Clearwater Osteoarthritis study that people are 7 times more likely to develop OA if they've reported a history of joint injury in the past. and a classic study by Lomander and colleagues has shown that, in female soccer players, that 82% had radiographic changes within the knee within 12 years following ACL injury, and 51% had OA by the time that they were approximately age 31. Again, this really emphasizes the importance of primary prevention and how critical that is. So recently, we've also begun to take a different approach to osteoarthritis and osteoarthritis management, with really trying to focus after somebody has had a joint injury on what can we do for secondary and tertiary prevention. And I think our perspective in terms of how we manage this disease or how we manage these injuries and potentially the long-term consequences is changing. And that's going to be especially important in the military population going forward. So due to all of these joint injuries, we also wanted to look at the incidence rate of osteoarthritis within the military. Again, we know that OA is closely linked to a history of joint injury, to acute traumatic joint injuries. So our question was, what are the incidence rates in the military compared to the general population? So again, we use data from the DMSS, or the Defense Medical Surveillance System, and the blue line on top are the incidence rates within the military by age category, and then the rates on the bottom are within the general population, rates that have been reported in the general population. So two things to note is that the rates were significantly higher within the military at each age group that we were able to make a comparison. And those rates, the difference between those age groups increased with increasing age. So we started out with about a 26% higher rate within the 20 to 24-year-old age group, and that increased to over 2 times as likely, or twice as high. The incidence rate was twice as high in those that were in the 40-plus age group. And again, these are the rate ratios. So again, from about a 26% higher incidence rate to 2.17 times higher incidence rate in military population, in those based on the age group when compared to the general population. So some colleagues, again, also looked at the incidence of hip OA, primary hip OA in military service members. Unfortunately, they did not look at, they did not make comparisons to the general population, but in at least a recent systematic review, we were able to do that. So again, if you look at males, age 20 to 49, the incidence rate was almost 4 times higher in military service members when compared to the general population. And when we look at females, it was the incidence rate was over 37 times higher. And again, we know that females are usually at higher risk for OA when compared to males. We also saw a trend where incidence rates, differences in incidence rates increased with increasing age in those categories where we were able to make a comparison. So a few other studies by a group down at the Army Institute for Surgical Research also looked at the battlefield orthopedic injuries and the major causes of disability. So again, these are fairly, these injuries are pretty much limited to battle-related injuries that required evacuation. So in terms of ranking these disqualifying or disabling conditions, degenerative arthritis, which primarily is osteoarthritis, by and large, was the most frequent reason for someone receiving a disability discharge in a disability code. Despite the frequency, the average disability rating for degenerative arthritis, we'll just say OA because it's pretty much OA is what we're talking about, is only a 15% disability rating. But when you combine those to look at the overall frequency times the impact or times the disability rating, osteoarthritis was, the third in terms of the impact of these unfitting conditions. And so up here, again, most frequent, percent disability, and then overall impact. So they conducted a follow-up study. So Jessica has since become married, so she changed her name from Cross to Rivera, just so you can keep track of that. But they looked at post-traumatic osteoarthritis due to these battlefield injuries. And again, because they weren't really sure, is this arthritis that people had before they sustained these injuries, or is this arthritis that was a result of these injuries? And in almost 95% of the cases that they looked at, the osteoarthritis that they reported was really attributed to that battlefield injury. And again, traditionally when we look at post-traumatic osteoarthritis, it usually takes about anywhere from 5 to 10 to 15 years to develop. But in these injuries that are sustained on the battlefield, the average time to develop OA, to go through the process of disability is typically seen in less than 2 years in these service members. So that's important to note. So we wanted to take a look back. They also did another study where they wanted to take a look back and see how OA has progressed or changed. They hypothesized that disability, the reasons that people were receiving disability discharge from the military had probably changed with the military operations that were ongoing. And they really didn't see much change. Again, osteoarthritis was the leading condition back in 2001 when Operation Enduring Freedom and then Operation Iraqi Freedom were initiated in the years following that, and those really did not change much. They swapped position, but overall osteoarthritis remained one of the leading causes of disability discharge with almost a decade after those combat operations had begun. And this looks at the change in average disability. So the average disability for osteoarthritis started out around 6% when these operations began, and ended up with an average of 12% disability rating for osteoarthritis in military service members. And again, if we look at, these are the impacts. So osteoarthritis and low back pain were the highest impact initially, and then again, almost a decade later, they were still at the top. Where PTSD had risen a little bit higher than that, primarily again due to the frequency and the impact of long-term care. So again, they concluded that in contrast to their original hypothesis that things would change, that regardless, after a decade of combat operations, that low back pain primarily and osteoarthritis were still the leading impactors in terms of disability discharge from the military. And this is a slide that goes back to data that's about 25 years old, and some of it actually is almost 20 to 25 years old. And again, you look back at the leading causes of disability. This is in the Navy. By and large is again osteoarthritis, degenerative osteoarthritis. Arthritis, by and large, remains the leading cause of disability discharge in the military. And these are the leading diagnoses that lead to these disability discharge ratings. And again, if you look, joint disorders, primarily related to osteoarthritis, internal knee derangement, osteoarthritis, other joint derangement, probably a high risk of osteoarthritis there, bone cartilage disorders, and then osteoarthrosis. These are all things that probably contribute to a large degree to the development of osteoarthritis in this population. So again, this is a full disclosure. This is what I was talking about earlier, but we recently had a book that came out, and Dr. Jim Fickey, who is the U.S. Army orthopedic consultant to the Surgeon General, had written this chapter for us on disability. I apologize. I should have set my phone on silent. Wrote a chapter on the reasons for disability discharge within the military. So it summarizes a lot of this work in that chapter if you're interested. So why do we see these differences? So we've already talked about joint injury. We know that joint injury is a leading cause of osteoarthritis. It's an unequivocal risk factor for osteoarthritis. Also, the literature has shown that people who are engaged in occupations that place high demands, require a lot of squatting, bending, and kneeling, increase the risk of osteoarthritis, and obviously military personnel do that. And then finally, while military service members are required to maintain minimum height and weight standards, so we don't really deal with obesity too much in the military population. A modern combat load can range from 52 pounds to well over 100 pounds. And we really don't know, and there isn't much research out there to show what impact those loads have on long-term joint health within this population. And this is just there's a kind of a link up here that references a study that they did looking at combat loads in the military. But these are just a couple pictures that I quickly pulled off the internet, and as you can see, these are very heavy loads that people have to bear within the military, and they typically have to do that for long durations, particularly if they're on road marches or they're moving. The loads can vary depending on the scope of the mission that they're on, whether it's a short duration mission or a longer duration mission. But obviously, we really don't know what they've done a lot of work to see what the physiologic strain acutely is in terms of whether or not our service members can handle these loads. But we really haven't looked long-term about what this means for joint health. And obviously, we know that obesity is a risk factor for OA, and I would assume that taking somebody who's healthy and putting a load on them, making them obese immediately due to the weight that they have on them, and not just that, the way that the weight is distributed, as you can see here. Soldier has to lean forward to kind of maintain that weight. We're not really sure what impact that has on joints. So what are some of the things that we can do to prevent this? Obviously, we need to focus on primary prevention for acute traumatic joint injury in the lower extremity, but also in the upper extremity. We also need to think about ways that we can monitor joint health over time and potentially develop secondary and tertiary prevention efforts for PTOA to mitigate the impact of joint injury and possibly delay the onset of osteoarthritis in these folks. And then finally, we need to really do a better job evaluating the impact of current loads that are used within the military and how those and figure out how those impact joint health, particularly in the long term. Another thing we can do that obviously is important is increase research funding. There are two programs that currently are related to arthritis in the peer-reviewed medical research program and the peer-reviewed orthopedic research program. But recently, I think just last week, there was an initiative in D.C. and on Capitol Hill to try and get funds that were dedicated to arthritis research and osteoarthritis research within the military because of the nature of this burden. And so just to wrap things up, acute traumatic joint injuries place a significant burden on the U.S. military population. These musculoskeletal injuries and conditions significantly impact force readiness. They have significant healthcare costs, and the long-term health-related quality of life impact on our military service members is significant. Post-traumatic osteoarthritis is a unique form of osteoarthritis that is associated with traumatic joint injury. And PTOA is likely to follow a much shorter time course than we typically see in primary osteoarthritis. For example, as I said earlier, following a joint injury like an ACL injury, you can see this develop within 10 years of major joint injury. And again, from a battlefield-related injury, this can occur within 2 years of injury. And these conditions can be quite debilitating. As we talked about, if you talk about an average service member who's in their early 20s, that means osteoarthritis, debilitating osteoarthritis following battle injury within a couple years, so in their early 20s, or in their late 20s to early 30s. So that leaves these individuals with a long life ahead of them where they're going to be living with disability. And I'm not sure the current disability rating takes that into account. There's also an increased risk for primary and revision joint replacement surgery in these individuals because they are so young. So not only will they potentially need an initial arthroplasty, but they may need a follow-up arthroplasty. And while there have been estimates in the general population that 12% of all OA cases are attributable to joint injury, I would argue that that is much higher in the military. And we're currently working to try and get some reasonable estimates of that, but we don't really have estimates of the incidence of post-traumatic OA in the military population, besides some of the disability data that we shared with you. And then finally, it's critical to develop effective primary prevention interventions to prevent acute traumatic joint injury, and then secondary and tertiary prevention interventions for PTOA within this population. So once somebody sustains a joint injury, what are the things we can do in the initial care and then during long-term follow-up to monitor joint health and make sure that we, if we can, we push the onset of OA as far to the right as we can. And I'd just like to thank you for taking the time to spend lunch with us, and I guess I'd be glad to answer any questions if you want to type them in the chat box.
Thank you, Dr. Cameron. A very interesting talk. You know, I think we pay so much attention in the general public to athletes and older populations in terms of osteoarthritis and don't think as much about the military and the significant impact that you've clearly demonstrated. And you also referred to the congressional briefing last week that happened with the Arthritis Foundation and the American College of Rheumatology. And, you know, it's just, I think there's a lot going on in this area for the military, and it's important to, you know, educate on the importance of these kinds of programs. And tomorrow, you'll see in the chat box, I put up a little bit of information about the briefing from last week, and I will put just a quick plug for tomorrow. There's a Twitter chat co-hosted by the American College of Rheumatology and the Arthritis Foundation. That's at 1 p.m. for anybody who wishes to join. It's part of the ACR Simple Tasks room chat, so do check that out. And I know you can see in the chat box we had one comment from Mark Hobner about the numbers. You know, could we get a copy of the PowerPoint presentation? Yes, we can certainly provide that, and his congressman is on the Veterans Affairs Committee, and we have his ear already, so that's great. You know, that's another thing that is, I think, helpful, is if people can reach out to their own congresspeople to address the issue.
Yeah, no, we obviously would be glad to share this information. You know, that's one of the challenges, is that I'm an employee of the federal government, so I cannot lobby Congress, but I'm glad to share information to people who can lobby Congress.
Well, and I have to tell you, we're kind of in the same boat here at the Osteoarthritis Action Alliance, because we are funded by the CDC, which is fantastic in many ways, but we also, you know, we look to our members to help with some of the more lobbying-related questions and advocacy and that sort of thing. So we like to educate, but we're not lobbying at this time. And our director, Lee Callahan, chimes in. Of course, we can share this information with Congress to educate. That's one of the things that we do, is we have a lot of congressional members on our mailing list and who receive our newsletters and information. So this is exactly the kind of thing that we like to share with them, so that they are well educated to know what's happening in the field of osteoarthritis and for which populations, so that they can make educated choices about policy decisions and that sort of thing. Great, and we have Mark Hobner, who will be bringing this to the Arthritis Foundation Summit on Capitol Hill, March 14th and 15th. So certainly anybody else can chime in with some questions. We are at our 12:30 hour, so I'll just make a quick announcement for the Lunch and Learn in March with Robert McLean from Harvard, so just keep an eye on that. And if anybody else has any questions in the meantime for Dr. Cameron, I'd be happy to entertain those. And certainly thank you, everyone, for joining us today. And thank you, Dr. Cameron. This is, like I said, very eye-opening, very interesting statistics on the significant impact of OA in the military. Much needed, I think, for everyone to learn.
I'm glad to be able to share, and would be glad to follow up if anybody had any additional questions or interest. And again, glad to share the slides. So thanks again for the opportunity. And if anybody has any questions, obviously they can contact me through you, I suppose.
They can indeed. I'd be happy to share any questions, or, like I said at the beginning, keep an eye out for this webinar recording on our website, and we'll be posting this on our web page. I'm sorry, on the website and on the YouTube channel. So there's plenty of ways to check out this, and we also post it on our Twitter page, and yeah. Plenty of ways to access all of our information. I see one more person typing in. We'll give her a chance to shout out. Oh, good. We have a former colleague here at the Thurston Arthritis Research Center who herself, Rebecca Layton, she is also a vet and is pleased to have all this kind of information. So thank you once again, everybody, and I think we will sign off for today. Thanks, Dr. Cameron.
Yep, thank you. And again, I don't know if this is consolidated in one place, but once you post it on the webpage, I guess we can refer people to that.
Yes, indeed. Thank you very much. Have a good day, everyone.
Thanks.